just to clarify for the audience, PTK is nothing but epithelium and some more amount of epithelium being removed with laser. So like in PRK, we actually mechanically remove it, and in trans PRK, what is done is first you remove 50 microns with the laser. Similarly, in PTK, you go a little bit deeper. Instead of 50 microns, you set it to 100, 110 microns, depending on what you feel like. So these are some of couple of cases. This is not in the sense a major complication, but something that bothers us very often from time to time. So if you notice, it's a fairly regular cataract, a smallish rhexis, but I mean it's always good if it's not a very dense cataract, better to have a slightly smaller than a slightly larger rhexis. So after the rhexis was done, we do a hydrodissection. This is Dr. Akahoshi's modified hydrodissection cannula. So the shape actually it sort of curves over the top of the lens, so easier to get a fluid wave. And notice here some hesitation in hydrodissection. So there are multiple areas being injected forcefully. If you notice, the wave has already occurred, but a case of in our what we would describe as excessive hydrodissection. Now notice here, a very innocuous thing has happened which we generally don't notice, and then things we feel that this patient had a floppy iris and things. But this is a situation of an excessive hydrodissection, and the cannula actually rubbing against. If you notice here, keep noticing the cannula, it will actually bruise the iris once. So iris is so sensitive, if you touch it once, that's the end of the story. It will just keep coming off. And so I think the excessive hydrodissection, and if you notice, this iris has now already started coming to the main incision. So even before you have started your phacoemulsification, you feel you are already in trouble. The best way to try and handle this iris coming to the incision is to try and inject a dispersive viscoelastic from top of on top of the iris from another incision. So never use the same incision to try and reposit that iris. It will always keep coming out, it will always keep coming out. So that similar principle was attempted to be followed, but because of ergonomic difficulty and probably excessive viscoelastic, it could not be achieved. So if you notice here, ergonomically the eye is not getting centered enough, and the cannula was unable to reach in that area of interest. So therefore that was not attempted. The second mistake is to
Shail, just a second. What I would like is, you mentioned inject dispersive. Is there any particular reason why dispersive and not cohesive?
That's a very valid point. The dispersive will stay there. So cohesive tends to come out as a bolus, whereas dispersive will tend to stay there on top of that iris and will be retained there. So therefore a dispersive and not a cohesive. The second mistake here is that very often we feel when nothing is working, just inject some viscoelastic inside the eye and things may probably help and deepen up the chamber. So there is already plugging and tight anterior chamber. We were unable to achieve what we wanted to, and therefore as a desperation we are injecting now more viscoelastic from the other side. And this is something that should always be avoided, use of metal instruments to try and reposit the iris, because the moment you use metal instruments there is a lot of pigment dispersion and it always tends to keep coming out. So ultimately the surgeon did feel that now the time is right, the chamber is formed, the iris is not in the incision, so let me go ahead with phacoemulsification. But while trying to introduce the phaco probe, the similar thing tends to keep happening. The iris keeps coming back, and then now you start to get desperate, you start to get panic, you see that the OT assistants are watching you, it's being seen on the screen that there is not something that's happening correctly, and then you inject this, again something that you do not require at this point of time, a viscoelastic through the same incision. So what will happen is that this viscoelastic will not only not go in, it will push the rest of the iris, keep pushing it out, and you keep bruising this iris with your cannula, you keep pushing it in, and however many times you may do it, it's never going to happen. So again phacoemulsification was attempted, but if you noticed, the iris started to come to the side port and ultimately sort of it was given up. So fortunately then little bit of sense prevailed, we loosened up the speculum, reduced the bottle height, the anesthetist put a little bit more of intravenous relaxant to the patient so that they relax a little bit, and then what we should have achieved the first go in through the side port and inject dispersive viscoelastic on top of this iris, so that that never comes out. And similarly, on the other side port, you'd never want to inject viscoelastic from the same side port. So we finally managed to inject some dispersive viscoelastic on both ends where the iris was coming out. And this is the time when you need to drop down on your parameters. So if you are using 70, 80, 90 bottle height, this is the time you want to drop it to at least 30-40% less than what you have. So at this point of time, we decided we want to start with the lowest infusion, that is 20 intraocular pressure. The reason why you don't want a higher bottle height is that the more fluid you give in, the more it is going to go behind the iris, and the more it's going to keep pushing the iris towards the periphery. So we went ahead with 20 intraocular pressure, and you notice now through the rest of the surgery, the iris is going to behave very, very normally. So while removing the fragments, because the fragments, they tend to touch the iris, because it's a smallish pupil, it does tend to come down from time to time. But the fear or the thought that we always have, okay, once the iris comes out, it will always keep coming out through the surgery. That's not always true if you are able to follow the principles of how to reposit the iris, and then make sure that your fluidic parameters are such that not much of fluid goes behind the iris. Another extremely important point in these cases is to make sure that your phaco probe remains in the center. So even while removing the fragments, whatever movements that you need to make, you do those movements, and when you are removing the fragments, the phaco probe should remain in the center. When you try and move the phaco probe in different directions to try and attract a fragment, what you do is you make sure that the fluid from these openings goes behind the iris in different areas and leads to further floppiness of the iris occurring. So make sure that your right hand remains absolutely stable and you stay all around. Now we did find that the pupil did come down significantly. Fortunately, the iris did not come to the incision. And a simple trick that helps at this time is just injection of preservative-free intracameral adrenaline. So if you notice, we have injected adrenaline, count 15 to 20 in your mind, and it will slowly make sure that the pupil will dilate sufficiently for you to do the rest of your phaco maneuvers. And if you notice, this pupil size is sufficient so that you are able to see the fragments that you are removing and able to do that nicely. Cortical aspiration in a small pupil is challenging, and very often what we end up doing, because we can't see, is that we keep catching the iris from time to time, and by doing that the pupil starts to tends to keep coming smaller and smaller. So here you need to follow the principles or steps of cortex removal, and I think they can be best described by remembering the acronym POPs. That is, P is first you position. So you first position your aspiration probe below the anterior capsule. Make sure it's below the anterior capsule and not the iris. So stay in foot position 1 when you do that. Second, you occlude that fragment with just a little bit of vacuum. Then you want to posteriorly detach those fibers and then swipe them, because if you do not follow that, some part of the aspiration port, if it is open, while you try and remove the fibers directly radially, you may end up catching the iris. So position, occlude, posteriorly detach, swipe, and only when you bring the fibers to the centers do you increase the vacuum. So keep noticing the vacuum parameters until the cortex matter comes to the center. The vacuum is very low, 50, 100 and so, and only when it comes to your visual area, when you see that the cortex is detached, do you step up on the vacuum. Once the cortex removal is done, you can go ahead with normal IOL implantation in the bag. Make sure that the haptics here, we are just making sure that both the haptics have gone behind the capsular bag, and viscoelastic removal behind the bag, irrespective of whether it's a toric or a monofocal IOL, I think should be done, and it can be done. So this was a case which can sometimes end up as a nightmare, that right from the beginning, if you have iris prolapse, the thought or fear in our mind is that you'll always keep having that all through the surgery, and the surgery is going to end up with lot of iris chafing and everything. But if you notice here, at the end of surgery, hardly any iris shaving, a perfectly round pupil, no sphincter atrophy and things. And this patient, obviously you want to give them non-steroidal anti-inflammatories for 6 to 8 weeks to make sure that they don't develop cystoid macular edema. But otherwise they are going to behave quite well and very similar to if you had not had an iris prolapse. So I think we need to follow these 2-3 principles. Make sure that if you don't over hydro dissect, over hydrodissection is one of the most common causes of the iris prolapsing. Make sure that at every point of entry of any instrument you don't touch the iris. These small touches of the iris can also trigger in a susceptible eye. And the third point, when there is an iris prolapse, never try and reposit it from the same incision. Go from the other side. If you don't have another side port, make another side port. That is more important, that this iris doesn't keep prolapsing. Inject dispersive viscoelastic and use much lower fluidic parameters than what you would normally want to use for your routine cases.
I think I'm just interrupting here.
Yeah,
this was an excellent case because this is something which I think all of us keep getting this complication very commonly, and these are the mistakes. Like I was just thinking that I actually go with cohesive first of all. That is the reason I asked you that why not cohesive, because every time I always thought that cohesive will push my iris behind, but as he said that maybe it comes out also faster. Again, we all have a tendency to go through the same wound. I think Shail has really given us excellent tips, because this is a very common complication all of us feel, that all of us come across. So go through the other side ports, use your dispersive, and again, in fact, I have a habit of using these iris repositors. I guess excellent tips, Shail. Thank you so much. No, basically when your iris becomes already like this, whatever instrument you want to push in, before that only the iris is coming. So you need to tackle the iris. Even if you go with your Simcoe or anything, the iris is going to come out if your Simcoe is also. And at this point in time, what happens is the moment iris keeps coming out, that causes iris chafing, iris atrophy, sometimes even the iris holes. So I think before we put in all these instruments, we need to take care of iris pretty well.
Yes, of course, if you find that this iris is not behaving well, you can of course use iris retractors. This is if try and prevent it from going to that stage, but there is no harm or there is no shame in using iris retractors or pupil dilating devices, for sure.
Again, one more excellent point which he said during his presentation is keep your parameters low, keep your bottle height low, keep your aspiration flow rate low, because aspiration flow rate again attracts everything towards your probe and towards whatever channels they have. So I guess excellent tips.
So this is another case of another seemingly innocuous situation. 40-year-old high myope already had LASIK done about 15 years or so ago. Most of these young myopes do tend to develop nuclear sclerosis at a far younger age than what most otherwise patients do develop. And she had significant astigmatism, and we had planned her for a toric IOL implantation. So for us at Raghudeep, that's a rule that if any complication has to occur, it always occurs in a toric or a multifocal. If you notice here, the patient is not cooperating well. The surgeon is quite hesitant. The centration is not good. That itself is a sign that gives you an indication that either the patient is not cooperating or the surgeon is a little bit more nervous than required. The capsular excis is being sort of initiated. Slow movements are being made, which is a very nice thing. Never be overconfident. And what is being missed out here is that because this eye is moving in different directions, the main port is being pressed with the cystitome. So the moment you press the posterior lip of the cystitome, the viscoelastic cohesive in this case while doing a capsular excis keeps popping out or keeps coming out. And the chamber tends to shallow, the eye is moving, young patients very uncooperative. Notice the eye is very much uprolled at this point of time. The excis is slowly starting to go out, all attempts are being made to bring it to the center. Finally the surgeon felt that probably it's time to actually inject some viscoelastic or try and hand it over to someone, because if you notice here, this direction is constantly going to the periphery. So at this point of time, it was decided that probably getting out is the best option. But keep noticing here. So you don't necessarily really require an intumescent white cataract for this to occur. If the patient is squeezing a lot, the chamber is not formed and the chamber keeps collapsing, and if you don't refill it adequately before time, this is something that can happen if there is a weak direction that has already been given. So now we have a situation that before starting the case, young patient myope toric, the rhexis has already gone beyond up to the equator on one side. So how do we go ahead with this case? The best way to now do is to try and convert the rest of the part into a stronger capsulorhexis margin. So we know we have lost the situation here. So now what we need to do is to try and convert it from the other side. So now what I'll be doing is injecting a heavier cohesive viscoelastic. Never inject on this side because it will suddenly lead to this entire tear wrapping around the posterior capsule. So go ahead exactly on the opposite side and inject cohesive viscoelastic on the opposite direction, and then make a nick on this side to try and convert the rest of the capsule that is there into a stronger capsulorhexis margin. So we made a nick and we are converting the rest of the capsulorhexis from the opposite side. Never attempt to touch this area. And at least except for this area of extension, you are able to give a strong margin to the rest of the 3/4 of the cataract lens that there is there. Hydrodissection is definitely essential in these cases. Here we are just trying to see if we can find the edge of the capsulorhexis, and we find it was fairly up to the equator. There is no point in trying to attempt to bring it back. So one point is to try and salvage the rhexis when it occurs, when such a situation occurs, from the opposite side. Particularly if the tear has gone beyond the iris, don't try from that same area to keep pulling it towards the center. It will always keep running out. Hydrodissection, you want to be gentle, but you do need hydrodissection. The reason is that if you don't have good hydrodissection, while rotating, you are going to put lot of stress in this area, which itself may lead to further extension. Once again, very important to use lower parameters as emphasized in the previous case. You don't want too much of turbulence occurring in this case, because excessive fluid will lead to disturbances. And whatever movements that you need to make sure that your movements are away from the area of the capsulorhexis tear. So here we need to be even more conscious that the right eye, while chopping and while fragment removal, doesn't move to the right side. Use whatever vacuum that is necessary, but use your left hand to make the separation forces, so that the separation forces are on the opposite side of the pre-existing capsulorhexis tear. And try and remove the lens matter as much as possible in the center of the eye, rather than going in any different direction. Notice here we've reduced the flow rate even further to 16 cc per minute, because we want things to occur very slowly under our visualization, under our control, so that there is no turbulence which can lead to further damage or extension towards the posterior side. So finally we were able to remove the lens matter without causing any further extension of this posterior capsular or this anterior capsular extension. And once again follow the principles of a closed chamber technique, that before withdrawing any instrument in such a situation, behave as if this is a posterior polar. So never allow the chamber to shallow, because the moment you allow it to shallow, this will wrap around and go around the posterior capsule. Again, cortex removal has to be done necessarily, but very slowly. We've reduced the flow rate now to just 10 cc per minute, because we'll slowly be coming to these areas which are likely to be weak, and you are likely to catch the broken anterior capsule as well. So use a high vacuum, but use a low flow rate, and therefore things you will notice are occurring very, very slowly, but it's always better to be slow rather than be sorry. So keep a very, very low flow rate, about 8 to 10 cc per minute. Use appropriately high vacuum, and if we follow these principles, we would more often than not be able to prevent this from extending to the posterior capsule. And now you can even consider a single piece toric IOL in the bag in such situations. So I think I would like to end here at this point of time, and if there are any other suggestions or comments, please feel free to share.